Is the second in a two-part series. And in our initial webinar, we discussed, some of the challenges around data collection and analysis. In this webinar, we want to focus on some of the factors that influence utilization of data for decision-making with SHP and health financing. So before we begin, I'm going to take us through a few housekeeping guides so that we are all as engaged as possible. So first of all, we ask that you keep your microphone muted and your phone muted as well so that you can pay attention during the session. We ask that you stay mentally and physically present. If you have a question or a comment, you can put it in the chat box or use the Q&A function. During the Q&A session, after the panel discussion, you will also be able to raise your hand and speak or share any lessons that you have on the topic. Most importantly, we really invite you to make this session as engaging as possible. We want to hear your stories. We want to hear your experiences. We want to hear some of the challenges that you have gone through with utilizing data in your line of work or in your country. And we want to share that with the team and have a very interactive and engaging session as much as possible. So feel free to share your comments if anything resonates with you from what any of the panelists says. We would be excited to hear from you. Next slide, please. So without further ado, I'm going to hand over to Boniface, who will help us to set the stage. Over to you, Boniface.
Thank you so much, Ebube, and good morning, good afternoon, and it's great to join with us as we have this important discussion for today. And just as we begin, it's just good to mention that SPARC, Strategic Purchasing Africa Resource Center, is hosted by AMREF and is devoted to providing governments with technical resources and assistance that help to strengthen their application of strategic health purchasing within their health systems. SPARC works with through partnerships such as the AMREF country offices, with technical partners who are mainly learning and research institutions that are based in their respective countries, and governments, so that we could be able to strengthen the application of strategic health purchasing. And it's also good to mention that strategic purchasing is a concept that allows us to use data so that we could be able to make three main key decisions. What to buy, that speaks to us about the benefit package, which providers to be contracted, and also the methods of contracting these providers, and then also how to pay for the services that the populations are entitled for, and that speaks to provider payment methods. So today in our discussion, we will be looking at how data is used to be able to enhance strategic purchasing decisions, and how we could be able to overcome challenges that affect data use, particularly for strategic health purchasing decisions. It's important to highlight that this discussion helps us to be able to delve a little bit into the Tanzanian health system and the Nigerian health system, with a view of, one, learning from their experiences, and two, also being able to see how that compares with other countries within Africa. It is my great pleasure to be able to have this session begin, and looking forward to seeing all your active participation during this very important discussion that begins now. Over to you, Ebube.
Thank you so much, Boniface. So the next session, we are going to have overview presentations from the different countries to help us set the stage and provide some context into our discussions during the panel discussion. So over to you, Raymond.
Thank you very much, Ebube, for this opportunity. As you have mentioned, I'm going just to highlight the DHFF in Tanzania and the data used in the implementation of DHFF, the electronic systems which are involved in the implementation of DHFF, and some of the challenges that we are facing in the I know that most of you are aware of the DHFF concept, so I'm just going to highlight in a nutshell. The government of Tanzania introduced DHFF way back in 2017 with the aim of implementing fiscal decentralization, but also strengthening autonomy of the health facilities in terms of resource management and utilization. And this initiative involves facility planning, budgeting, and reporting of funds that are received in the health facility bank accounts directly from the treasury. But again, we have seen the introduction of direct health facility financing in Tanzania has led to improvements in data management at facility level to ensure effective utilization of funds, accountability, and enhance the service delivery. It has also significantly enhanced the data used for decision making at the facility level by providing direct access to financial resources and necessitating robust data management practices. Next slide. The introduction of direct health facility financing in our country has also been a catalyst for the development of a number of data systems. The systems support the efficient management of funds, ensure accountability, and enhance the overall performance of health facilities. These systems, we have different types of systems that facilitate implementation of DHFF, as I have said, ranging from systems that collect data from nutrition services, systems that deals with the health insurance fund, but also we have a system that manages the improved community health fund. We have PlanRep, that is a system for planning and reporting at the facility level, and so many other systems that are used to facilitate implementation of DHFL. So all these data systems help us to achieve better health outcomes to ensure sustainability in our health financing reforms. However, we have challenges that hinder smooth implementation of data use in the DHFL. We are facing data literacy and analytical skills for data-driven decision making. The health facility staff also lack skills in monitoring and evaluating health outcomes to ensure that funds are used efficiently. As you know, we need capacity to enable facilities to demonstrate the impact of their financial decisions and reinforce their autonomy. So these are some of the challenges that the health facilities are generally facing in terms of data management. Over to you, Ebube.
Thank you so much, Raymond, for that very succinct overview. I'm now going to hand over to Dr. Nina to take us through an overview of the Nigeria system. Over to you, Dr. Nina.
Thank you very much, Ebube. And I'll be looking at the Nigerian system, how we leverage data for decision making, looking at the political economy. Now, just to give an overview of the Nigerian system, we have a country where we have a three-tier system of government at the federal level, then the state level or subnational level, and also the local government level, which recently they got autonomy. So at each level, you also have different aspects of the health system. So the health system is modeled along that three-tier level as well. So you have 36 states and a federal capital territory. That's like 37 states in all. And at the federal level, you have the Federal Ministry of Health and Social Welfare, with its agencies, including the National Health Insurance Authority. And at the state level, you have the state ministries of health. You also have the state health insurance agencies as well, and other organizations. Then, like I mentioned, you have the local government areas as well. So within this complex structure of multiple states, multiple actors, service delivery divided between primary care, secondary care, and tertiary care, some of them private, some of them public, some of them demand side, some of them supply side, some of them local actors, some of them international actors. We have myriads of health information systems, sometimes at the facility level, sometimes at the subnational level, and sometimes within an ecosystem, for instance, for the health insurance. But I think it's also important to state that when it comes to healthcare financing, it's also a little bit mixed. We have some the government funded, which is mostly tax-based. We have out-of-pocket expenditure, which is over 70% in the country. We have health insurance, which covers mostly the formal sector, and we have a large informal sector population, which is still largely uncovered, even though for the health insurance coverage, we have actually moved from about 16 million people at the end of last year to about 18.5 million in 2024. So there's progress within health insurance space, but the informal sector is still largely uncovered. And we also have donor funding and some vertical programs as well. So that gives you a sense of how complex the system is. But nevertheless, there's been a lot of gains in terms of the healthcare financing space. For instance, the National Health Act of 2014, which establishes the health system and also establishes the Basic Healthcare Provision Fund. We also have health insurance being decentralized to the subnational levels in 2015, which has also made some improvements in resource mobilization. And then we have the National Health Insurance Act of 2022, which transforms the NHIA into a regulator, promoter, and integrator of all health insurance schemes. That act also establishes the Vulnerable Group Fund, which it gives an opportunity for more vulnerable people to be covered under health insurance. And so those are some of the things that are happening within this space. Despite the complexity, there are lots of opportunities. Next slide, please. Great. So this just gives a sense of how the data flows within the system. And if you look at the first column that looks at the levels, we see at the bottom there, the communities, and then the local government, the state level, and then the federal level. If you look at it from a perspective of a public sector and private sector, this breaks down the public sector into the ministries, providers. Primary healthcare came out prominently because of the role it plays, and also the health insurance ecosystem. Then we have the private sector at the end. Taking a look at the ministry, like I mentioned, we have the Federal Ministry of Health and Social Welfare at the top there at the federal level. And so if you go all the way down to the community, under the third column, you see community health influencers and promoters, that's CHIPs, traditional birth attendants, and other health workers at the community level. And so they attend to people in the communities, and data generated, and that goes, some of it gets to the primary healthcare facilities, where they also generate data on service utilization as they're seeing patients. And that data is collated and goes to the local government health authority, which now gets up to the state ministries of health and also to the Federal Ministry of Health and Social Welfare. So that's one pathway. But also, when you look at the third column, where you have the secondary hospitals and the tertiary hospitals, see that secondary hospitals, they also submit data to the state ministries of health through their hospital management board. And then the tertiary hospitals also submit data to the Federal Ministry of Health. In fact, it's a Department of Hospital Services in the Ministry of Health. But these same tertiary hospitals also, where they are accredited by the National Health Insurance Authority to provide services, they also give data to the National Health Insurance Authority as well. And so also do the secondary hospitals at the state level and so on. So you have data going different ways. And for the primary healthcare, data from the primary healthcare facilities also goes to the state primary healthcare development agencies and all the way to the national level. So same thing for the private sector. If you go to the last column there, we have healthcare providers at different levels, whether they are providing primary care, secondary care, or tertiary care. And those that are accredited by the National Health Insurance Authority also provide their data. Then we have what we call the health maintenance organizations, which are private organizations that work within the health insurance space, either providing private health insurance or also being middlemen in the social health insurance space. So they also give us data. And then we have development partners, some of them running vertical programs or supporting the government of Nigeria. And then we have civil society organizations, faith-based organizations. So a lot of actors within the space across the different levels, a lot of data. Sometimes if you look at the primary healthcare facilities, the workers are actually under pressure to give data to different organizations and different groups. But I just want to highlight that for the National Health Insurance Authority, if you see that big bubble at the bottom there, some of the data we collect is around the contributions that people make, how much of it is contributed, and how much of it maybe is paid out of pocket. We also are interested in looking at the subsidies that we pay. For instance, I mentioned the Basic Healthcare Provision Fund, which is established by the National Health Act. There's an NHIA gateway where funds are provided for the provision of the basic minimum package of health services, mostly to the vulnerable people. So how much of that money is also tracked? We want to know how many people are being enrolled under health insurance. We want to know the quality of services that are being provided. We want to know how many patients are actually coming to the hospital, what kind of services they're utilizing. We want information from the claims, and then what kind of complaints are we getting? How many complaints are, how many are resolved? And this last slide, just to highlight the importance of data and digitization. This is the strategic direction or blueprint of the Federal Ministry of Health and Social Welfare. Our goal is to save lives, reduce both physical and financial pain, and produce health for all Nigerians. And you can see at the bottom there, the foundation, data and digitization features very prominently. We want to digitize the health system and have data-backed decision-making. So in a nutshell, just to highlight what the system in Nigeria looks like, the various actors we have, the complexity of it, and also the opportunities and the importance that we attach to data and digitization in Nigeria. So I'll just stop there for now. Thank you.
Thank you so much, Dr. Nena, and thank you so much, Raymond, for those very concise and yet robust overviews. So I think, there a lot has come out of those presentations, and I think we should, take this opportunity to dive deeper into some of the challenges and some of the key points that came out. So my first question is to you, Raymond. You had mentioned one of the challenges that you highlighted with the DHFF, and I'm hoping that a lot of us here are familiar with the DHFF, but Tanzania has done a really good job with directing payments directly to health facilities in order to improve access and quality of services. And so as you might expect, having those funds channeled directly to the facilities raises the question of capacity of health workers to manage those funds and to be able to utilize the data that they have to make decisions around, health financing and strategic purchasing at the health facility to improve their service delivery. And so, Raymond, you had highlighted that there is the challenge of the capacity of health workers around data literacy and analysis. And I was wondering if you could expand on that. What are the specific challenges that we have with health workers and their capacity to utilize this data in terms of data literacy, analytics, and what are some of the methods that have been used to improve their capacity in this regard? Over to you, Raymond.
Thank you, Ebube. As I have mentioned that there are literacy capacity as far as data management is concerned among the health facility workers. I can group this in 4 or 5 aspects. One, the health workers have limited understanding of just the basic data concepts. When we talk of data quality, data management, statistical analysis, these are some of the basic data concepts that most of the health workers do not understand well. And this hinders, therefore, the ability to collect, interpret, and use data effectively for decision making. Another challenge is the health facility workers do not have adequate training or capacity in using data tools. The data management tools such as data systems that we use to collect, analyze, and interpret data. We have DHS2, we have PlanRep, just the systems that I mentioned earlier. Most health workers are struggling to use these tools effectively, and this leads to incomplete and inaccurate data entry and analysis in general. Again, we are facing poor data analysis skills among the workers, where they cannot analyze and interpret data to draw conclusions when they make decisions. Another challenge, there's an inconsistent data reporting practices where inconsistent data reporting affects the reliability and the practicability of data information across different facilities. And finally, the national level where policy decisions are made. The last problem or challenge is limited use of data for decision making. We can see that generally we have a lot of data. Data is available, but many health workers do not routinely use data to inform their decision actions, and this limits the potential impact on data-driven improvements in health services that can be done. So those are the gaps that I can mention as far as data use is concerned among the health workers. What we have done so far is the government. We have different initiatives as far as training and education programs are concerned. Our government, in collaboration with various health organizations, have implemented different training programs to improve data literacy among health workers. This is through workshops, seminars that are focused on data management, analysis, and use, specifically the health information systems available in the health sector, such as DHS2, PlanRep, etc., etc. But again, we have the on-job training and mentorship We use experienced data managers and supervisors to offer on-job support and guidance to the health workers in data collection, entry, and analysis. This has shown improvements among some of the health workers in the health facilities in the use of data. Again, integration of data literacy in the health trainings curriculums. This initiative is done in the health training institutions where curriculum for different data programs are included. And we have such trainings programs like health informatics in the curriculum of medical and nursing schools. But again, we have strengthened data reporting standards by establishing and reinforcing standardized data reporting protocols and guidelines across all health facilities. The Ministry of Health always provides clear guiding on data reporting requirements and conducts regular audits to ensure that there is compliance. We also conduct supportive supervision and provide feedback to reinforce good data practices and address the gaps. Lastly, we collaborate with partner international organizations to provide technical assistance as well as funding and different resources required for data literacy initiatives. We have programs supported by, for example, by the World Health Organization, the UNICEF, that enhance data capacity in the health sector. So in a nutshell, this is what I can provide for now. Back to you, Ebube.
Thank you so much, Raymond, for that response.
Hello,
Yes, go ahead.
yeah, maybe thank you, Mr. Raymond, because you said it all, but apart from the capacity of the staff at the lower level, which is one of the challenge which we are facing for data use and the other issues on DHFF. There's the issue of HRH shortage also, which I think is cross-cutting to many countries, because we have a huge shortage of human resource at our facility. So there is that's one of the challenge which makes our health workers not to document some issues and because of the workload. Also, there's issue of poor communication system due to remoteness of some areas, and ICT is not working function well at that remoteness area. I think this also is cross-cutting to many African countries. But apart from those solutions which Mr. Raymond mentioned, we assigned the expertise to each local government authorities and the facilities to provide support to our health workers in the issue of data use and how to manage data and how to analyze data and how to operate the issue of DHFF and this all system at the facilities. And also there is a political will the government have been undertaken financial reform and enhancing the implementation of ICT improvement and interoperability of or these operating system like FAST, PlanRep, Epica, and the other system in the at the facility and the local authority governments. But also we are trying to build a local capacity for effective financial management to our people. So that's in addition to say that these are the measures which are usually as a government we do take to make sure that we tackle this data literary challenge to our health workers at the facility and the local government authority. Thank you, Ebube.
Thank you so much, Dr. Dastan, and thank you so much, Raymond. A lot of key points coming out from that in the area of, poor data analysis tools, inconsistent data reporting, and then some of the solutions that you have implemented around the trainings of health workers. I'm sure they have been, and I actually would want to ask how effective these trainings have been. But before I come to that, I just got a lot more questions out of that. But before I come to that, I want to give Dr. Nena an opportunity to share with us. Dr. Nena, from your presentation, I think it's very clear that the system in Nigeria for health financing is extremely complex and has a lot of stakeholders that are involved. And I'm sure experts in health financing here will probably see a lot of the challenges that may arise from this. But I wanted to ask, what are two key challenges, if you could mention, that the NHIA faces in terms of utilizing data for decision making in SHP, and particularly from the angle of the political economy of engaging stakeholders. How does that system play out when the NHIA wants to make a decision? What are some of the challenges that you face with that process? Over to you, Dr. Nena.
Yeah, thank you so much, Ebube. And a lot of challenges, yes, but like I always like to say, even within that, there are lots of opportunities. So the key challenges we face not just at NHI, but within the health insurance space, when it comes to utilizing data for decision making, I think the most important one would be the multiple fragmented databases. As I mentioned earlier, you have databases within organizations, you have databases within ecosystems, and so on and so forth. And in a lot of cases, they are not interoperable, so they just stand alone. And so even within an organization, you can have a department that has its own database, or another department, and they don't speak to each other. You can have a program that has its own database. You can have a scheme. Like I mentioned, we have 36+1 states, and each of them have their own schemes for the formal sector, informal sector. And sometimes you have databases that are not connected. So how do you begin to move? Maybe somebody wants to move from one state to the other and access care. It makes that difficult. So that's one major problem, the fragmented databases. Another thing is the lack of standardization. It's difficult to harmonize all those data sets because different templates, different data sets are being used, different tools are being used. Some of them are paper-based. The system is not fully automated. And so sometimes we have tried to use Google Forms and get, the data online directly from the facilities and the other stakeholders as well. But when you're doing that, you also have to bear in mind that, especially from the facilities, you must have electricity, you must have the right equipment, maybe laptops, you must have data, you must also build capacity. And so you'll permit me to add a third one, which is capacity. I think that's really, really key. Capacity varies at various levels. And when it comes to data, I think it's good to break it down. Let's not just say capacity for data management generally. There's a capacity to even identify the data you want to use because if not, it's garbage in, garbage out. How do you know what you're supposed to be collecting? And then there's a capacity to accurately collect that or record it, and then you need the capacity to even analyze it. You need the capacity to transmit it, especially electronically if it's going to a higher level. And then there's also the capacity to use it for decision making. So a lot of capacity is really needed, especially when it comes to the facility level. And what you often find is that there's no feedback to those levels. All they are told to do is just collect the data in whatever form it is, and then send it up, and decisions are taken, and they don't know what the implication for that data is for them at the facility level or lower level. So if we're going to decentralize analysis of data, we also need to decentralize decision-making authority. People need to have that capacity as well. So we begin to ask ourselves, what is the critical must know that anybody who's handling data must have? And then you can now separate that from the specialized skills that people need. And we try to address some of that with the NHI leadership program, give people some of those critical must know skills. So in a nutshell, I don't want to speak for too long. I think if you address the issue of the multiple fragmented databases by, integrating them, I know people have invested so much in ICT and they may not want to give that up, finding a way to integrate them virtually, standardizing all the tools, which we have tried to do significantly with the Basic Healthcare Provision Fund, and then building that technical capacity at various levels to handle data and use it for decision making. If we can handle those three, I think that would solve a lot of the problems we have around utilizing data for decision making. Thank you.
Thank you so much, Dr. Nema, for that response. As you were speaking, I had sort of a brainwave, and just permit me to ride on your response that you just gave to ask another question. So you had mentioned that the capacity to even identify data at the basics, what kind of data they need to use at the different levels might be a challenge. And so I have a question around that concerning the availability of guidelines or job aids that can help health workers or health program managers at different levels identify what kind of data. So basically around capacity, do the health workers, do the health program managers have job aids or clearly defined roles in terms of data collection, data utilization? Do they have that data so that they can actually use it to make decisions? And in a case where they don't really have access, is it more of an issue with, like you mentioned, the fragmented system? So maybe, for instance, the data they need is collected by another system or by another program. And how has Nigeria managed to provide this kind of sort of capacity strengthening so that health workers and health managers at the subnational level actually, first of all, know what kind of data they need and what kind of decisions they are allowed to make?
Thank you, Ebube. So I think the best way to answer your question would be to use the basic healthcare provision as a good example, because the issue of job aids, it's both, it's a whole health system. It's both demand side and supply side, yes. So for using the BACPF as an example, for the NHIA gateway, even though we're demand side, we have our implementation protocol, right? And we have a section of that protocol that deals with the monitoring and evaluation. It has a framework, the indicators, the data reporting flow, and who's supposed to do what. And based on that, templates have been developed for data collection and trainings have been done. And I know in some of those trainings, it's not just the data reporting officers or the M&E officers, it's also the CEOs that were people that take the decision and people who collect the data were both invited, and it was a hands-on training and they got to see how it was used. Not to forget that it's also the responsibility of the supply side, because they engage the workers. to also provide some of those job aids and training as well. But the beauty of the Basic Healthcare Provision Fund is that we work together, all the gateways, to provide that training that is needed. And we've also harmonized some of our tools, especially around quality assessments, and I think so a little bit around the M&E as well, to be able to make sure that the capacity is built at the subnational facility levels. But it has to be a continuous exercise, because I mean, you have turnover of the workers at the facility level, and we also have changes politically and also within the health sector as well. So as there are developments coming up, you need to continue to reinforce those trainings and to make sure that there's also supportive supervision as well. Yes, I hope that answers your question.
Yes, thank you. Thank you very much. Allow me to backtrack back to Raymond and Dr. Dastan. And I think my question here is, we know that, for the DHFF, health workers have the autonomy to sort of make decisions around forecasting and budgeting and all of that. I wanted to ask if you could share an example with us of how health providers or health facilities have been able to utilize the data they have to improve financial decision making, which has led to an increase in quality and access to health services. Over to you, Raymond and Dr. Dastan.
Thank you, Ebube. Let me start by saying one of the notable examples of how health providers in Tanzania have utilized data to improve financial decision making. We have the Got Homies system. This is a software platform. The long form of this is Government of Tanzania Health Operating Management Information System, which is used in facilities to collect, report, and analyze health facility data. In data collection and reporting, health facilities collect various health data on different health indicators, including patient visits, treatments provided, but again, financial resource collection and expenditure. This data is entered into the GoToMC system on a daily basis to ensure up-to-date and accurate information is always available. But again, they use the data from the system for financial monitoring. The data that comes from GoToMC is designed for financial data management as well. So the facilities can always track collections and exemptions and analyze the facility outcome, facility income on daily basis. And this data is also used to identify areas where financial resources are being under-collected, and therefore they can always take informed actions to correct that one. The facility staff also have been using data for resource allocation. For example, where they analyze data and find there's more patient load and service is demanded, then they can always conduct reallocation of finances in order to make sure that the services are provided in an optimal required level. So these are some of the examples that the health facilities have been able to use that. But let me allow me to give a specific example where we have different regions in our country, and one Kigoma region, which is situated in the western part of Tanzania, facilities have been able to utilize data for monitoring maternal and child health services by utilizing data. They identified a need for more midwives, for example, and more delivery rooms. So they used financial data, which revealed areas where budgetary reallocations could cover the identified needs without any additional funding. And as a result, later, the maternal and child health outcomes improved with higher rates in attended deliveries and reduced maternal and infant mortality rates. This is a specific example that I can cite from Kigoma region. Thank you.
Thank you. Thank you so much, Dr. Dastan, for that. That's a fantastic example that shows how facilities utilizing data can improve service provision. Just to mention to the audience that you can feel free to put any comments or questions you may have in the chat box or using the Q&A function. We really want to hear your experience. So please feel free to share any experiences, any challenges, any similarities with the challenges that the panelists have mentioned, and any recommendations to improve these. We're excited to hear from you. And yeah, we'll keep an eye out for your comments or questions. Now, as we continue with the panel discussion, I think I'll just continue with you, Raymond and Dr. Dastan, and ask if there are any systemic challenges that further hinder the capacity or the efforts to build capacity of health workers on data utilization. And then do these challenges also affect the ability of these health workers to use the data to make decisions? For this question, I'm looking around accountability mechanisms that sort of guide how health workers, or the level of autonomy that health workers have to make the decisions, even though they have the data. And what lessons can you share from that aspects? Over to you, Dr. Dastan Raymond.
Thank you. What you can say is that the facilities in the country at large face always hinder the capacity of the health workers to make the sound decisions that are required in their daily undertakings. I can mention one very big challenge that Dr. Dunstan mentioned earlier is insufficient, human resource shortages. We are running a very big shortage of human resource in the PHC level at around 52%. And this affects to a great deal how the health workers make decisions by using data. When we have few workers in a facility, this always overburdens the available staff and always cannot deal with data management, but they always decide to deal with clinical duties of our data management tasks. So shortage of staff is a very big problem to us. Again, we don't have sufficient fund when it comes to capacity building and infrastructure development to invest in the necessary training and technology. We we have a very big, very vast area to cover in terms of the number of facilities and as well as the number of health workers that are required to be trained. But again, insufficient funding affects how we provide motivation and incentives to the available staff. If you cannot motivate the available staff, it always leads to the staff being feeling that they are not recognized, and therefore they will not be able to or to address the data-related tasks that are in front of them. We also have infrastructure deficiencies. This was also mentioned by Dr. Dunstan earlier, that some of the facilities are situated in very remote areas where there's no electricity, there is no internet connectivity, there is no adequate computers. So it's always difficult to deal with data for decision making. But our country has been able to implement a project, electrification project, for quite some time now, and that problem of lack of electricity is fading out slowly, and we hope that in a number of years to come, we'll be able to make sure that all the facilities are connected to the electricity lines. We have another systemic problem, and this is the data quality. We are facing consistent data quality, fragmented data systems, and sometimes lack of standardized data collection methods that pose a very big barrier. So in a nutshell, this is what I can say are some of the systemic problems that we are facing as far as I'm concerned. Thank you, Ebugo.
Thank you so much, Raymond. And I will circle back to you to find out, what are some of the strategies that Tanzania is implementing to address these challenges, especially the challenge around the health workforce, which I think is a challenge for most African countries. But before we get to that, Dr. Nena, I wanted to give you an opportunity to provide an example of when the NHIA has been able to navigate the complex political landscape of varying stakeholders in Nigeria to make any changes to the strategic purchasing function. And I'm linking this to the question that was asked in the Q&A section, which asks if we have examples of the use of data for purchasing purposes, for instance, have benefit packages or rates of payment mechanisms been adjusted based on data analysis. So Dr. Nena, do you have any example of how the NHIF has been able to utilize data to make some of these strategic purchasing decisions or changes? Over to you.
Yeah, thank you so much, Ebube. So definitely NHIA has been able to use data to make some of the strategic purchasing decisions. As a strategic purchase, we wear many hats: a big regulator, promoter, integrator, strategic purchaser as well. And one of the things we do is to we pay for services from accredited healthcare providers for some of our programs. And so that means there is a benefit package for the formal sector, which comprises the organized private sector and also the public sector programs. And this benefit package from time to time has been reviewed based on the data that's been collected. Also, the pricing too we've recently reviewed, we tried to review the tariffs. We have also contracted some actuarial scientists. That review is going on. But in the meantime, what NHIA has done is to increase the capitation by 60% and the fee for service by 40%. And that was a stakeholder inclusive process. It included a lot of data gathering to know the prices of the drugs in the markets and the prices of services across the country. Also getting feedback from the stakeholders in terms of what should be included in the benefit package going forward based on advancements in technology, advancements in healthcare delivery, and so on. So yes, we have been able to use evidence, both from the costs of services and both from the services that are being provided to update provider payment mechanisms and prices, as well as the benefit package. So we do that a lot. There's also how data also helps us is also in terms of complaints. We have an enforcement department, and complaints management has been decentralized to our state offices. We have them in all the states. And so every month, all the complaints that come in are compiled into a complaints register. The number of complaints that came in, how many were resolved, and how many were not. And that is compiled, analyzed. And then we also see the facilities that have the highest complaints, and we look into them and see what's the cause, because it becomes a quality issue as well. So that helps us track the kind of services our beneficiaries are getting. It also helps us track the performance of the facilities and helps us track how well we're doing in terms of resolving the complaints, even as we try to be more proactive and make sure that there are zero complaints across board. So those are just a few examples of how we use data. Yes.
Thank you. Thank you so much, Dr. Nena. And to the audience, please keep the questions coming and your comments as well as your experiences. We are excited to hear from you. There's a question from Gilbert in the Q&A section that goes to Raymond or Dr. Shana. We know that effective strategic purchasing is related to priority setting during the planning phase. Are there specific initiatives or strategies to improve planning? Raymond or Dr. Mshana, who wants to take that?
Thank you, Ebube. Maybe before Raymond responds to that question, there's a question which you posed before you invited Nina from Nigeria about the HRH shortage. Actually, the government of Tanzania play a big role on deploying the HRH. Within 3 years, actually, the government employed more than 15,000 health workers. And these are specific to the local government. When we are talking about health system or health sector in Tanzania, there is a central and local government. These 15 health workers who are deployed by the government within these 3 years, specific for Mama Samia leadership, is very specific to the local government authority. That means for specific for primary health care level. Currently, the government advertised for employment specifically for the local government and central government also. And I think in this financial year, the government planned to employ more than also 15,000 health workers for local government authority. I mean for primary health level. So we are trying to push to minimize, to reduce the gap of HRH burden. And also we have the program called community health workers. This, I think, initiated by the WHO. And we have a program of training. I think it will be short training for 6 months, and deploying the community health workers. Although this will help to fill the gap of HRH shortage. So these are mechanism of government to fill this gap of HRH shortage. I think because this HRH issue is specific on the desk of Raymond, can you add something there? And also he will answer the question from the participants. Raymond, please.
Thank you, Dr.
Yes,
Dastan.
yes, Dunstan, you have just said it well. Let me go straight to the question on the chat section about whether there are initiatives or strategies to improve planning for effective strategic purchasing of services in relation to priority setting in our country. We have been implementing a number of initiatives, and under the Ministry of Health, we develop health sector strategic plans. This is a multi-year health sector strategic plans that outlines key priorities, resource allocations, and implementation strategies. But also we have health financing strategy that focuses on improving financial protection and increase efficiency in resource use, as well as enhancing equity in access to health services. This one also includes mechanisms for strategic purchasing to align with funding with health priorities. We have the National Health Insurance Fund, as well as the Improved Community Health Funds, which are responsible for purchasing health services for their members. They use strategic purchasing to negotiate contracts with healthcare providers and ensure services are provided and align with the national health priorities. So those are just few initiatives or strategies that we have as far as planning and prioritization for effective strategic purchasing of health services. Thank you.
Thank you. Thank you so much, Dr. Dastan, and thank you, Raymond, for your responses. I'm going to move to the next question. We have 2 more questions. So audience, please feel free to ask any other questions that you have. There's a question from Ojochide. Please, I'm sorry if I murdered your name. And his question is, as the global south to north migration and rural urban flux of health workers is accelerated by push and pull factors, in what ways do speakers see international development like partners like the WHO and the IOM iterate their support to the process, because the human resource for health pillar is key to the functioning of other health systems pillars, especially in the context of underdevelopment. Iterative steps are likely needed as we approach 2030, and the gaps exist in the health-related SDGs. Thank you. So I think I'm going to pose this question to Boniface. Boniface, are you there?
Yes, I am.
Great. Are you able to respond to Ojochide's question?
The one on Tanzania?
No, the one on the health worker shortages, and how international development partners can support.
I think it's two ways. Many times when development partners would support, it would be a short-term arrangement. And this is because if we are making progress towards universal health coverage, then what we really need to be able to still keep encouraging our governments is to take that temporary arrangement, but ensure that there will be sustainable financing for the health sector from government. And that way, we would progressively then deal with the challenges of healthcare worker shortages. Second thing that is also important is to be able to work out on better mechanisms of deploying healthcare workers according to, and then using data. The reason why this is absolutely important is that when you look at all our countries at this point in time, we now have more healthcare workers than we ever had in the continent, despite the fact that we still have challenges such as brain drain, and we still have challenges where government sometimes is not fully able to absorb all the trained healthcare workers. But there are still challenges around deployment of healthcare workers to the key to meet the key health needs, and this is the part that we would need to encourage governments to utilize data a little bit more judiciously, so that we are then able to effectively allocate, and we are able to effectively monitor the performance of the existing, healthcare workers. And this would help us then to be able to optimize the available resource, even as we continue looking for additional resources, from other sources to ensure that we can be able to employ more. The third thing that's also important is to begin to also see the place of technology in augmenting the work that the human resource are carrying out. And here, our proposal is not that we would automate everything, but the use of technology helps to conserve, some human resource efforts, and ensure that then you can redeploy the existing staff in more direct engagement. The fourth and the last one is where we have concepts like task shifting, where we would then ensure that some of the work that is not necessarily technical can be shared by other non-technical staff. And that way, you don't engage a technical staff to do the day-to-day mundane work that could be actually, shifted to another person, and that way avail, more time for healthcare workers to be able to offer the more required technical work in the course of provision of health services.
Thank you. Thank you so much, Boniface, for that response. And as you were responding, it brought to mind that, organizations like AMREF have, done a lot in terms of human workforce or health workforce development, capacity development. AMREF's Institute of Capacity Development has trained a lot of health workers across multiple countries, both pre-service and in-service training, just to increase the skill level and the availability of qualified health workers to provide services, especially at the primary healthcare level. An example is in South Sudan, where AMREF has been very instrumental in, providing trainings for midwives, not just in South Sudan, actually, in a lot of the African countries where AMREF has offices or where AMREF operates. And I think that as international organizations seek to support countries, they shouldn't just provide that short-term support, as Boniface mentioned, but then also work to sort of incorporate some of these best practices, some of the necessary skill mixes into the pre-service and in-service trainings that go on, just so the health workers, as we know, information changes, skills need to be developed and refreshed. So health workers can continue to develop their capacity as they go on. There are several examples, and I encourage you to look at the AMREF website to see some of the examples and some of the ways in which AMREF has supported health workers to develop their capacity, even using digital technologies such as the LEAP platform in places like Ethiopia. So if you have some time, please check out the website and see some of the examples of the ways that we've supported health worker capacity development in countries. There are two more questions. There's a question from Ishak around cervical cancer, and I think this I'm going to pose to Dr. Nena because he was specific about Nigeria. And the question is, I'm wondering if panelists think it is possible to have a free cervical cancer screening program for Nigeria or Africa within the current funding streams for healthcare in Nigeria and Africa. Dr. Nena, do you have any comment on that?
Can you take the question again? It was breaking, maybe my network.
Okay. So the question is, he's asking if it is possible, or if you think it's possible, to have a free cervical cancer screening program in Nigeria within the current funding streams for healthcare in Nigeria and Africa.
Okay, thank you so much. I think preventive care is really, really important. I mean, it's something that we need. And as a woman, I know the importance of cervical cancer screening. But if you come to healthcare financing, if you look at it critically, there are trade-offs that you need to make. And so you need to look at the amount of funds that are available. Just looking at Nigeria or whatever country you have in mind, how many people are actually contributing to that, pot? Where are you getting your funds from? Is the government mobilizing funds? Are people contributing? Are they paying out of pocket? If you have a big enough pool, both in terms of the risk pool and the financial pool, you might be able to cover not just cervical screening, but also some other high cost interventions as well. So it's just like the UHC cube. I don't know if you're familiar with it. You'll have to make some trade-offs in terms of how many people you can cover, how many benefits you can also cover, and then what kind of costs you can also cater for. But yes, I think cervical cancer screening is key. It should be covered. I mean, it's something that is really, really important. But you also need to look at the cost. And then and also looking at the cost, don't look at it holistically. You might be able to cover the full cost. You might be able to cover parts of the cost as well. And then people now need to pay a top-up or something. You might be able to do that cervical screening for somebody just once in a lifetime or multiple times. So there are various ways of looking at it. So yes, important, feasible, yes, but it depends. Thank you.
Thank you. Thank you so much, Dr. Nena, for that response. Very key to highlight that there are always trade-offs to be made when considering health financing for different services, because unfortunately, there is no country that has unlimited funds to spend on healthcare. And so you have to decide, to what level you can support, or you can sponsor, a country can sponsor different types of interventions and the impacts that we hope that they'll have. Our final question is from Haley. And I would request, Haley, if you could unmute and ask the question if possible, so we can hear your voice. Okay, let me allow you to talk. Haley, are you able to speak? I think your question is really important around private health facilities, which we haven't really touched much on during this session. So if you want to ask it, please feel free to. Okay, Haley is unable to speak. So I'm just going to read out the question and I'll pose it as an open question to both the panelists from Nigeria and from Tanzania, because I think it's an important question. So the question is, how is the capacity of private health facilities to generate quality and real-time data in both country and the government leverage? Is there a unified system for data monitoring for both government and private facilities? I think I'll start with Raymond, and then Dr. Nina, you can also chip in. Raymond?
Yeah, thank you, Ebube. As far as Tanzania is concerned, we have increasingly focused on generating high quality and real-time data from both public and private facilities. And there are different initiatives that include the private facility staff in the capacity building programs. When we recruit public facility staff for certain programs, in terms of capacity building, we also call upon the private facilities to bring their staff so that they can receive the same and equal dose of capacity building. The challenge remains where we don't have enough funding to accommodate many of these private health facilities programs. So we are still looking forward to see how best we can go about this so that capacity is built and strengthened across all types of facilities, including the private sector. Thank you.
Thank you. Thank you so much, Raymond.
On top of that, in Tanzania, we encourage PPP, private-public partnership. And the issue of data in health sector is on government, is a government issue. So the tool we use to collect data at the government facility is the tool also used to collect data at the private sector facility. And all data are monitored by the government, health data. And for example, if you are the district medical officer at the certain local government authority, you have to make sure that all private facility at your area, they are bringing data at health data at the end of the month, as the government facility do, so that there's a specific person for data. We call them focal person or HMS focal person at the district level, who usually collect all data from the government facility and private facility and send it through the DHS tool. So we do monitor. Also, we build the capacity to private health workers, private facility health workers, as Raymond said. But also we usually do we monitor them through we say in every quarter we do visit the private facility to build them capacity, to strengthen capacity, to make sure our people are on the safe hand. They are treated with a qualified person, and the data which are collected with a well qualified person. So we build the capacity to them, we monitor them, and we make sure they all health data are belong to the government for the government use.
Thank you. Thank you so much, Dr. Dastan.
Finally,
Dr.
Ebube, I can also just add
Okay.
on the point that Dr. Dastan has just given, just to say that when we talk about strategic health purchasing, we also encourage governments to think about purchasing health services from private sector, and that way one is able to integrate them into the day-to-day, as opposed to where we have the private health sector on this corner and the government sector on that corner. Because if the government purchases services from the private sector, then it becomes a lot more easier to be able to work with the private sector to ensure that that data is even collected, in addition to other strategies like the one that Dr. Dastan has said.
Thank you. Thank you so much, Boniface, for that. Dr. Nena?
Yes, thank you so much, everyone that has spoken. I totally align with what you've said, especially what Boniface said about public-private partnership. And we do that a lot in health insurance. We have private health providers who are part of the system, and we easily get data from them. They're accredited by us. And it's funny, a lot of people go there, even though people go there because there's this element of trust that the services or perception, the services are much better than public healthcare facilities. We also have, like I mentioned earlier, health maintenance organizations who implement private health insurance, and we regulate them, as the NHI regulates them. So there's also that public-private partnership in the health insurance space. At the level of the Ministry of Health, we also have the DHIS2, as was mentioned, for Tanzania, and they have the health facility registry. So ideally, all the data should go to the ministry. But there was something Dastan said, it's the government that needs the data. So the government should make extra efforts to reach out to those facilities and get the data. And this would be so much easier if there was automation and if we just plug in and get that data. But the system is a little bit skewed towards public healthcare facilities, which are disproportionately funded more by the government, because, I mean, they pay the health workers, they pay for trainings on data management and other courses as well, and they pay for the infrastructure. So the private facilities do not have the benefits that the public have. But I think what is really important is that there's the role of the private sector cannot be ignored or overemphasized, and we need to make sure that the data we get from them is used in decision making, and we also give them feedback as well. Yeah.
Thank you. Thank you so much, Dr. Nena. Thank you to all our panelists. Thank you to everyone that has spoken and has contributed to this very engaging and I think very interesting conversation. Several key points have come out from this, and I think one of the key ones is that the challenges we face around utilization of data are very similar across all of the countries that have chipped in. And some of the challenges include, and I think the biggest one is the fragmentation and poor interoperability of the different data systems that exist. There's also the challenge of capacity at the health facility level and also subnational and the national level. There are system issues that exist, of course, across most low LMICs, including, the issues around infrastructure, around human resources for health. And we've heard some of the recommendations and some of the ways that these countries have addressed that. Key amongst this is training of health workers. And as was mentioned in one of the comments and one of the questions, there's a lot of, especially in Nigeria, there's the brain drain that is going on. There's the there's the increasing urbanization. There is, the limited, basically several factors that affect, the amount of health workers that we have available. And so it's important to identify innovative ways to ensure that we continue to build the capacity of the health workers that we have that are existing, but also work with governments to, governments have to prioritize increasing the number of the skilled health workforce that's available to them, so that they can continue to provide services, high quality services to the population. As we bring the webinar to a close, I want to thank everybody for joining. I want to thank once more our panelists. If you can just turn on your videos and wave before we go. But yes, I would love to thank all of our panelists for contributing, for sharing with us. I think this has been very interesting. I look forward to, us sharing the key messages with all of the participants here. The next steps for this will be to put together the key messages and to share with all the participants that have been in attendance. I want to thank you once more for your time and for your contributions. We look forward to having you at the next SPARC webinar. Thank you once more and have a great rest of your day.
Thank you, everybody.
Yes.
Thank you.
Thank you,
Thank you.
everyone.
Thank you.
Thank you.